Hello, everyone, and welcome to today's Café Talk, Pain and Joint Management in Aging for Bleeding Disorders community. As people with bleeding disorders live longer and healthier lives, retirement becomes not just a milestone, but a new phase to prepare for carefully. It is a time when the legacy of past joint bleeds often meets the natural process of aging, making pain management and joint preservation our top priorities. To stay healthy, active, and independent, we must rethink our daily routines, adapt our physical environment to support our mobility, and adopt proactive strategies to manage chronic pain before it limits our world. To discuss all this, I'm joined today by Dr. William McKeown, a geriatrician with extensive experience supporting older adults with chronic conditions, and an EHC Steering Committee Member, and Anna Wells, an advanced practice physiotherapist in Haemophilia at Hampshire Hospital's NHS Foundation Trust UK. Thank you both for being here. My name is Daria Camilli, and I'm the Education and Communication Manager at the European Haemophilia Consortium and the host of this program. My first question goes to William. William, when we speak about joints and pain, is it exclusively about patients with hemophilia?
Not at all. Pain is a universal human experience, not specific to haemophilia or bleeding disorders. In fact, humans have evolved to feel pain as a protective mechanism, warning us about injury or potential danger. When people lose the ability to feel pain, it can actually cause harm. So, for example, at the moment, I have a patient with diabetic nerve damage who struggles to feel her feet. She got a foot ulcer after burning her foot on a hot radiator because she couldn't feel the heat till it was too late. I think it's important to come back to what we mean, though, by pain. Pain is commonly defined by the International Association for the Study of Pain as an unpleasant sensory experience that also has an emotional element, and it's associated with actual or potential injury. So, this highlights that pain is both a physical and a psychological experience. And as we age, many factors can contribute to pain, such as osteoarthritis, other medical problems such as angina, changes to how the brain processes pain, particularly in people with dementia or memory problems. But for people with bleeding disorders, we have further complexity of dealing with pain from joint bleeding and the psychological impact of living with a chronic condition. And that layers additionality onto the usual pains associated with aging.
Thank you, William. Anna, we often talk about the success story of modern hemophilia care, but for aging patient, this success comes with the legacy of joint damage from decades ago. How does the clinical approach change when we move from managing a 30-year-old to managing a 70-year-old with a bleeding disorder?
I mean, it can be different, but then also it's really similar in that we'll try to look at each person as an individual. So from a physio side of things, we'll obviously look at those physical aspects. We'll look at range of movement, we'll look at strength, we'll look at balance and control. But more importantly, a lot of our focus is really around function and trying to understand what's important to that individual. So that could be sport, that could be hobbies, but that could also be remaining independent in their own home. And obviously, there's been big changes in terms of treatment. And what that hopefully is giving us is that each of the people that we see with bleeding disorder should have a really minimal sort of risk of bleeding. So those limits, those sort of function activity limits, we should be able to push those for each person, regardless of age.
William, many of our community members worry that pain is simply an inevitable part of getting older. How do you help a patient distinguish between normal age-related morbidity and specific hemophilic arthropathy?
So that's a really common concern. Although I would push back on the idea that pain is inevitable. Although it's common as we age, it's not something that we should accept without question. What I usually say to patients is first, try to understand the pattern of your pain. With age-related general issues such as osteoarthritis, wear and tear arthritis, you tend to get a more gradual mechanical pain. It builds up over time. It's worse with use. It's fairly predictable. Haemophilia joint pain can look different, so patients recognise a more episodic pattern, flares, sometimes like to bleeds with swelling, warmth, a reduced range of movement, and a sense that the joint just isn't right. There can also be a history in that affected joint, so target joints, previous bleeds. So these flares or bleeds do not happen in isolation. The other key thing is a change. So if a patient tells me that this feels different from my usual aches and pains, I always take that very seriously, and patients will know what is normal for them. I think that's often the clue that something more specific is going on, especially when the pain is severe, especially when pain is waking somebody at night. I think the final point on pain is don't normalize pain too quickly. Whether it's aging or haemophilia related, pain is a signal. Our job is to interpret that signal properly, because if we can get that right, there's often a lot we can do to improve and treat pain.
Thank you. That's really important what you said. And Anna, I believe that as a physiotherapist, you often see the physical fear patients have. If someone hasn't been active for years because they were afraid of bleeding, how do we safely introduce movement back into their lives in their 60s or 70s?
Yeah, it is difficult. If for a lot of people, obviously they've been told that pain often might mean bleeding. So that's can be quite an ingrained belief for a lot of people, and so that's quite difficult if then we're saying, well, actually pain probably isn't bleeding now, and there's still going to be very much that fear, and that will have an effect on what that person does in that situation. So more often than not, pain will mean kind of stop and reevaluate, and so it's just trying to build it gradually, try and get people to build confidence in their physical self. And again, if you can link into what's important to them, trying to link into those to that sort of motivation around what is important to them. For any of us, behavior change is really difficult. So if we can link into something that person wants to do and get some shorter term goals, longer term goals, then that's going to really help.
So in a way, you also work as a psychologist to those patients to support them to start doing some movements without fear. Okay, I have another question to you. We know that joint replacement or orthopedic interventions are a common topic in our community. What is the role of physiotherapy in the pre-habilitation phase, meaning preparing the body for surgery, and how does it differ from standard post-operative recovery?
So it's often it's really quite similar, I suppose, from our side of things. From physio, it's in the pre-operative stage, it's a lot of it is around strength, trying to work with what we can, those restrictions around range from physical joint changes, obviously, that are there at the time, and pain restrictions as well. So strength and balance and control are sort of key areas, and then maintaining or maximizing range as able, really. And I think it's really important to talk through those sort of physical things around the operation itself, and if there's going to be mobility, so if someone's going to need to use crutches, or if someone's going to be in a sling, or whatever those post-operative restrictions may be, just sort of making sure we kind of talk through all of those. One of the key things that I do is that you mentioned about psychology. I think there's that overlap, isn't there, with sort of physical and mental health, but I think definitely having that conversation around how that person's feeling about that surgery, because I think often, unfortunately, many people have had experiences that in hospital that might lead them to feel quite nervous or worried about things, and potentially even put off having surgery. So I think it's important to have those conversations and then link in with those psychology colleagues if needed.
Absolutely. We recently had conversations within this project, Living Well, Aging Well, about home adaptations. And it was extremely interesting to hear both from clinicians and patients about what is important to do as we age. And I want to ask you how much of joint management is actually about the environment, the chairs we sit in or the stairs we climb versus the clinical treatment. My question goes to both of you.
Well, if I can jump in first, for me, when it comes to older adults, treatments that don't involve medication can often be a better option because we know older adults, especially those with frailty, are at a far higher risk of side effects from painkillers and may be less likely to derive benefit from painkillers. Often one of the best treatments for musculoskeletal pain is not more tablets, but to keep moving in a way that is safe and sustainable. And as you've alluded to, this is where home adaptation can be critical. So a common example is adding the second stair rail to make stairs easier to do, to take load off painful knees, to engage the upper body and allow people to go up and down their stairs with more ease and more confidence. Indeed, other home adaptations which reduce strain and stability can even protect target joints, and they may even lower the risk of bleeds. So really, the environment isn't separate from treatment. It's actually a core part of the holistic approach alongside physiotherapy, prophylaxis, and painkillers.
So yeah, I mean, I agree. It's an area that can really make a big difference to somebody. And from a physio side of things, obviously it works kind of hand in hand, really, as physios will encourage people to maximize their strength, their range, their cardiovascular fitness. But it's really, really worth linking in with our occupational therapy colleagues and trying to get a home assessment and see what can help. Definitely.
Thank you. Yes, we had a conversation with William and occupational therapist exactly. It was extremely interesting, and I want to invite everyone to go back to that conversation and listen also to our patients like Jim and Yannick, who shared their experience, how they dealt with home adaptation. Extremely useful. I have my next question to William. Let's talk about the pain ladder. In aging populations, we have to be careful about polypharmacy, the one that you mentioned, taking too many medications. What are the specific risks for bleeding disorder patients when using standard over-the-counter painkillers, like non-steroid anti-inflammatory drugs, for example?
So something that the doctors often talk about is the World Health Organization pain ladder. This is a tool that we use to guide picking appropriate medications for the severity of the pain. So, for example, for mild pain, a mild analgesic such as paracetamol often will be a safe and effective treatment. However, as pain increases to moderate or severe levels, people often will need stronger pharmacological pain relief, like morphine or tablets that specifically target nerve pain, like gabapentin. For example, if somebody broke their hip, that is likely going to cause severe pain. They might need intravenous morphine. Paracetamol would not be adequate in that case. One of the problems is that often stronger painkillers can have more significant side effects as we age. So take morphine as example. Whatever age you are, morphine has side effects, but in a younger person, it may well be tolerated better. But in an older person, they may be more likely to get confusion, sleepiness, constipation, or even in severe cases, breathing difficulties. One of the classes of medications you highlighted specifically were non-steroidal anti-inflammatories. So especially for people with bleeding disorders, anti-inflammatories or NSAIDs such as ibuprofen or naproxen are often discouraged because they can stop platelets working and they can actually make bleeding risk higher. Actually, with the emergence of more advanced therapies, sometimes these treatments are beginning to use, but I would say to everybody, you should only be using these under guidance and supervision from a haematologist. I don't want to give the impression that painkillers are always bad. Actually, the right painkiller in the right situation can be an enormous help. However, as I've said already, the risks of side effects in older people is so much higher that there needs to be careful consideration given to that risk-benefit decision. And whenever I'm prescribing painkillers for older people, my key mantra is start low and go slow, i.e., if you start with lower doses of medication and you don't increase the dose too quickly, you're far more likely to avoid some of those side effects that aggressive or thoughtless prescribing can bring.
Thank you. Anna, beyond medication, what are the non-pharmacological tools that actually do work? We hear about hydrotherapy and even mindfulness. What does the evidence say for our community?
So, I mean, the evidence specifically in bleeding disorders for pain management is limited, but it's an area that is expanding. Obviously, physiotherapy fits within that, exercise. There's also good evidence for psychological therapies, visualization, distraction, and I'm particularly interested in EMDR, so eye movement desensitization reprocessing for pain management. For me, I think the more that we can understand about pain for each individual is the really sort of key. I think if we can help somebody work out what those both physical and non-physical things that may make someone's pain worse or make someone's pain a little bit easier, that's a really important thing to do. I did a focus group last year for a research project, and one of the key things that came from that was around peer support. And I think that's something, you know, obviously as clinicians, we try to understand as best as we can, but we haven't lived that life and we haven't, you know, walked in those shoes. And I think if you've got somebody else who can understand what it might be like living with pain and having that history of sort of bleeding and that side of things, I think that's really valuable.
Thank you so much to both of you. Before we close, I would like to ask you for one golden rule for an aging person with a bleeding disorder who wants to prioritize their mobility this year. Anna?
So I think I was thinking about this, and I think it was a film or something that I was watching, but it talked about this thing called marginal gains, and it's just around if you've got one person who makes one small change or one small change on one day, and if you build that, so it doesn't have to be a big thing. So if you can just make one small change on one day that moves you in the right direction, then do that.
Thank you. William?
I think my takeaway would be treat pain individually and treat pain holistically and not just with tablets. Always consider physio, exercise, tablets, and your mental health if you're looking to get on top of your pain.
Thank you, Anna and William, for these insights. For those watching or listening, please visit the EHC website to find our guides on healthy aging. Join the conversation. And thank you again to our guests.
Thank you.
Thank you. Bye-bye.